And today he's going to give us a lecture on device therapy for heart failure. What's new? If I can pass over to you, Simon.
Thank you. And thank you very much, David. And ladies and gentlemen, it's my honor to be invited to give this evening lecture today. So in the next 30 minutes or so, I will try to summarize what's the newest area in the device therapy for heart failure. Now, in terms of device heart failure, we actually have learned from the European guidelines and many other guidelines that now device treatment become an indispensable part in the management of heart failure patients. Now you can see in the ESC guideline, for those patients with heart failure and a reduced ejection fraction, if they got a wide KRAS complex, they should be candidates for cardiac resynchronization therapy, versus if those heart failure patients with a EF less than 35%, they should consider ICD therapy if this patient got a narrow or normal KRAS complex duration. Therefore, I would like to more focus on the newest device therapy, CRT, and also another new device called the CCM. I will briefly mention about ICD therapy to complete the story. Now, we know that there has been a large number of ICD multi-center clinical studies addressing heart failure issues. And these studies, such as the MEDIC-2, the DEFINITE, and also the SCUT-HEF study, they actually found that in those patients with reduced ejection fraction, namely less than 30 or 35%, there will be a substantial reduction of all-cause mortality, in particular sudden cardiac death. So as you can see in here, the relative risk reduction is more than 30% uniformly observed in these clinical studies. Therefore, right now, the indication of ICD is actually class 1A in the prevention of secondary prevention of sudden cardiac death in those patients who got a ventricular arrhythmia causing hemodynamic instability and also the survivors of sudden death. And bear in mind that because of many of these positive studies, right now there's also a class 1A indication for ischemic etiology of heart failure if they have a reduced EF, typically less than 35%, and also a class 1B indication also for non-ischemic etiology as well. Therefore, there's no doubt that for either primary or secondary prevention, a low ejection fraction becomes the single most important governing factors for the choice of the device. Now, what about cardiac resynchronization therapy? This is an area which is not very new anymore, because I can recall that the first device I ever implanted is about year 2000 in China and also in Hong Kong. So I was invited to be the first implanter in mainland China. I think since then, this treatment has been actually developed and evolved very quickly. Now, to recap this therapy, this is an implantation of a device that connects with the coronary sinus with a left ventricular lead, which will pace the left ventricle, which is the region of mechanical delay. And on top of that, the right ventricular and the right atrial lead will be implanted in order to coordinate atrioventricular and also biventricular contraction. Of course, the right ventricular lead could be an ICD lead in case of the CRT defibrillator device. Now, this device's therapy of CRT has been shown to improve symptoms, quality of life, exercise capacity. It reduces heart failure hospitalization, and also it reduces all-cause mortality and also sudden cardiac death. And in fact, the reduction of sudden cardiac death is also shown to be effective even based on the use of CRT pacemaker platform. Here to just recap again some of the examples of CRT pacemaker therapy, such as a CARE-HF, and also the use of ICD, such as companion HF study. Now, this study unanimously actually shows the reduction of all-cause mortality. Say for CRT pacemaker, the meta-analysis found a reduction of mortality by 34%. And here is the meta-analysis of a list of studies. Again, it shows a reduction of all-cause mortality by 42%. So it's actually slightly bigger than the use of CRT pacemaker. Now, of course, the MEDIC CRT study focused patients mainly with class 2 heart failure. 80% of these patients were having a class 2 heart failure, and these patients with a YKRS and also a EF less than 30%. Now, this study is unique because it tried to compare the ICD therapy alone versus the use of CRTD, and yet there is 34% reduction of the primary outcome measures of combined mortality and heart failure hospitalization. Now, the benefit of CRT on cardiac function has actually been shown as well. It improves left ventricular systolic function by having a better ejection fraction, higher cardiac output, and also it increased diastolic filling time, especially after optimization of the AV timing. It caused reverse remodeling of the left ventricle and also reduced the degree of mitral regurgitation. So this is a classical study that has been actually cited almost 1,000 times by now, on the role of reverse remodeling and resynchronization of the ventricle. This study actually shows that for those patients who receive a device therapy, there is a gradual improvement of ejection fraction in the next 3 months. And when we withhold the pacing, you can see that there is a gradual deterioration of EF down to the pre-treatment level again. And very similarly, here it shows a reverse remodeling with the reduction of left ventricular end diastolic and also end systolic volume after CRT. And also without pacing, you can see that the on-off effect is very obvious, and also the left ventricle enlarged again. Therefore, right now, the use of CRT in class 3 to 4 heart failure patients have a class 1A indication if those patients got a left bundle branch block morphology on the KRS, if they have a LBBB with a widening KRS more than 120 milliseconds, and a reduced EF less than 35%, already put on optimal medical therapy. Now, for non-LBBB morphology, the recent guideline is actually have upgraded the use of the device preferably in patients with a KRS duration of more than 150 milliseconds, so no more 120 milliseconds, and also with a class 2A indication for conditions similar to those patients with LBBB pattern. Now, what about for those patients with class 2 heart failure? They are having a relatively mild heart failure symptoms. Again, if they have a LBBB morphology, they need to have a KRS duration of 130 milliseconds. EF has to be lower, less than 30%, and also put on optimal medical therapy. Now, for non-left bundle branch block, again, it requests the presence of a longer, It requests the presence of a longer KRS duration of 150 milliseconds with a class 2A indication for the therapy. Now, why this is relevant? Because we actually have learned from years of experience that those patients with a borderline KRS compressed duration between 120 to 150 milliseconds may not respond very well to the therapy. So here is our study that compared the degree of left ventricular reverse remodeling in those patients with a LV for assessment of end systolic volume, ejection fraction, and also exercise capacity. Now here, the right-hand panel shows that those patients with a very wide KRS of more than 150 milliseconds typically respond much more than those patients with a borderline KRS of 120 to 150 milliseconds in terms of reduction of left ventricular volume, improvement of ejection fraction, and also increase in the exercise capacity. Therefore, responders rate in the very wide KRS is actually 68%, while the responder rate for the borderline KRS duration is only 46%. Here is another meta-analysis published a few years ago trying to examine the impact of KRS duration. Now, for those patients with a wide KRS more than 150%, you can find that in fact CRT consistently improve mortality irrespective of whether this is class 2 or class 3 and 4 heart failure, with at least 40% reduction of all-cause mortality and also heart failure events. However, for those patients with a KRS duration of less than 150 milliseconds, in fact, there is no clear clinical evidence of any heart endpoint reduction, and therefore it is recommended nowadays that you got to have either a typical left bundle branch block pattern or a very wide KRS of more than 150 milliseconds in order to have a good response. Now, the MADIC CRT also tried to analyze left bundle branch block versus non-left bundle branch block pattern, and it actually shows that, again, those patients with typical LBBB receiving CRT-D is much better than ICD by a reduction of mortality and heart failure event. However, this is apparently not present in the non-left bundle branch block pattern. So recently, the long-term follow-up result of MADIC CRT studies is also published in the New England Journal of Medicine and also announced in the ACC. In that, they actually follow up this patient for very long duration. And here you can see that about almost up to 7 years of follow-up, you can find that those patients also in the left bundle branch block will have a reduction of all-cause mortality and heart failure event, and the number need to treat is only 9. So it is an extremely cost-effective therapy. However, for those patients with non-LBBB pattern, in fact, there is a little bit of even more alarming signal that those patients who receive the therapy do not actually having any benefit in terms of mortality for the non-bundle branch block. And here it shows that those patients with left bundle branch block with heart failure events, either fatal or non-fatal heart failure events, will be reduced in the LBBB pattern. So therefore, it is consistent also with the current guideline. And many of this information is actually already documented in our recent update in the European Heart Journal, and Dr. David Haynes is a very important co-author of the input. Now, what about the new or evolving issues in the CRT? I think I would like to address a few key issues here. First of all, is whether how we are going to predict CRT responders and the role of dyssynchrony assessment. Now, in order to predict a response, we need tools to actually assess mechanical dyssynchrony, and I think the most validated tools will still be the use of echocardiography. Now, in echo, there has been a number of dyssynchrony parameters being developed, which has been illustrated in the guideline paper in the JACE in 2008. Now, this includes the use of longitudinal assessment of the long axis motion by tissue Doppler that map out the septal to the lateral wall systolic velocity delay of more than 65 milliseconds. Or we can actually make it a little bit more comprehensive. Apart from measure the septal to the lateral wall delay, we can make use of the 3 apical wheels, the 4-chamber, 2-chamber, and also the 3-chamber wheel. Therefore, we will map out on the 12-segmental model what is the standard deviation of the peak timing. So it's a matter of scattering, which is for this, the cutoff value is more than 33 milliseconds. Or we can also find out what is the maximal difference in the delay, which is 100 milliseconds as the cutoff point. Now, alternatively, we can also measure on the echocardiography on the radial delay, which is the short axis fiber delay. Now, either the use of M mode for the septal to the lateral or posterior wall delay on M mode of more than 130 milliseconds, or by use of the speckle tracking to measure the delay between the septum and the posterior wall with a delay of 130 milliseconds in the mid-cavity level for the radial string delay as proposed by Dr. Gorson. Now, alternatively, we can also measure on the interventricular delay between the left ventricular and the right ventricular outflow with respect to the mechanical onset of contraction. Now, intuitively, normally the left ventricle should contract before the right ventricle. However, in the desynchronous left ventricle, it will contract after the right ventricular outflow activation. So if any delay more than 40 milliseconds will be a marker of significant interventricular dyssynchrony. So here is a way or a mapping of the delay as shown by the tissue synchronization mapping. Now, in normal situation, the color coding will be green, but any delay will be gradually coded as yellow, orange, and red. Therefore, in this heart before therapy, you can see a large area of delay in the mid-septum and also the basal lateral wall. Now, this has been significantly improved after CRT, and you can actually see that the dyssynchrony index actually improved from 65 to 30 milliseconds. And remember, the 33 milliseconds is the normal cutoff value. So here is another patient with a borderline KRS complex duration. You can actually find that this patient do not have a high level of dyssynchrony because the regions are actually coded in green color despite a borderline QRS duration. And this patient, after pacing, we actually find that there might be inducing a high level of delay at the lateral wall. Therefore, the TSSD parameter increased from 21 to 31 milliseconds after CRT. So it has some indication that if you have a patient without a high level of dyssynchrony, you give them a device, this patient might actually be iatrogenically induce a high level of dyssynchrony, therefore affecting their response rate. Now, there has been some negative studies, including the prospect and so on, which we believe might be related to the intrinsic limitation in terms of the site selection and the training, which is not actually dedicated, and also the choice of a large number of dyssynchrony parameters, the use of older generation echo machines, which is not able to measure dyssynchrony comprehensively, and also the focus of the device company is really driven on the implantation on a higher volume of patients rather than cut off the numbers. Therefore, we believe that the solution in the future is really to consider a very dedicated training for, and also the use of workshops to train not only the implanters but also the cardiologists performing the synchrony assessment. Therefore, we have to work closely with the EP colleagues in order to promote a collaborative effort for comprehensive assessment of the synchrony. So here is what we are doing in Asia. We actually organize dedicated echo training workshops, hands-on workshops in the last 10 years. We focus on not only on hands-on skill but also offline assessment to reach a highly reproducible result, and also they will be certified after the 3-day course. And we actually certify them, and therefore they are able to be qualified to measure the synchrony and also make use of the high-end technology such as the tissue Doppler, speckle tracking, and 3D echoes, etc. Therefore, here is, I think, my analogy. You can see a gentleman in the park. He's just dropped something. So I think the message here is that we shouldn't judge too quickly and also based on the snapshot of what you have seen, but rather we need a comprehensive picture of the whole story of the incident or the event in order to judge what is the best way for our patient care. Now, having said that, we also have seen some very positive data. For example, this is the data from Dr. Gorson, who tried to compare our index of dyssynchrony that he called the U index, and also he used his index of radial strain delay. With this cutoff value, he was able to show that for those patients who got high level of dyssynchrony receiving device therapy, they got a much better prognosis than those patients without a high level of dyssynchrony before implantation. And further to this, I think what he tried to illustrate a very useful point is the complementary role of use of dyssynchrony on top of KRS duration. As you can see in here, for those patients who got a wide KRS of more than 150 milliseconds and also a high level of dyssynchrony, these patients will have a very good prognosis. Now, for those patients who got no dyssynchrony and also a borderline KRS between 120 to 150 milliseconds, they got a very poor prognosis. Now, for those patients who got one favorable factor, they will have intermediate prognosis. Here is also another way of make use of the assessment for myocardial function before implantation. So here you can find that the assessment of circumferential strain at baseline and in a patient after CRT. Now this patient, you can see that the strain value increased from 16 to 26 on average, and also the segmental regional contraction become much more synchronous than before. So this patient is clearly responding nicely to the therapy. However, this is a non-responders. First of all, this patient remain having a very low strain value. Most of them are actually above 5%. And also some of them are paradoxical. And you can see that the heart remains desynchronous and also strain value remain low after CRT in the non-responder. Now, we believe that there is a reason behind, because the circumferential fiber are actually the reserve fibers in heart failure patients. Therefore, if you have a patient who actually not only suffering from the impairment of longitudinal SS function, but also the short SS function is also bad, as illustrated by a low circumferential strain, this patient will not have any myocardial reserve at all. Therefore, we think this is probably too far gone, and also this is beyond repair in such a situation. When this patient reaches a point of no return, no matter what you do, they probably will not be having a favorable response to CRT. Therefore, we got to find out whether this patient will have a decent circumferential strain and radial strain. If they do, they tend to respond better. If they got a low strain value before therapy, they usually will not respond much after device therapy because the myocardium is too sick. Now, this is a study from the Leiden's group who actually examined 397 ischemic patients, and they try to make use of cardiac MRI and compare with the strain, and they show that a strain value less than 6.5% will be equivalent to more than 50% of the scar tissue. So first of all, they find that those patients with a high level of dyssynchrony, they will have a much lower all-cause mortality after receiving CRT. And secondly, those patients with a lower scar tissue, as illustrated by higher mean strain value, they again will have a lower mortality after CRT. Therefore, if we can look into this model, trying to actually illustrate the point that the use of different assessment model will have incremental prognostic value in these subjects, including a high level of dyssynchrony, a concordant left ventricular lead position, and also a lower level of scar tissue. Contractility will actually predict a better outcome in patients. Now, we are trying to also go beyond that, because we believe that in order to best predicting response, we need to go through a more comprehensive parametric assessment model. Therefore, we are trying to combine different factors that might actually affect the prognosis, including the QRS duration and the pattern, etiologies of heart failure, the level of dyssynchrony, the left ventricular geometry, contractile reserve, biomarkers, and possibly other markers, and we will give them a scoring system in order to predict the CRT response. So that is the so-called Predict CRT study, which is still ongoing. So here is some of the insight on the matter of echocardiography and dyssynchrony and its relationship to CRT response that we had published a few years ago. Now, what about the issue of implanting more than one LV lead into the heart? Is that going to be helpful? Well, I guess there's no easy way, because first of all, we know that the area of the so-called sweet spot for the ideal lead implantation could be variable. But then, based on animal study, we know that in order to place a LV lead into the left ventricular free wall, usually this so-called sweet spot is quite large, so which is a reassuring news. So that actually allowed the opportunity to implant more than one LV lead. So this is an example, and also the pilot study by Dr. Christopher Lacroix, who actually implant 2 LV lead, one at the inferior lateral wall and one at the superior lateral wall, based on the access to different branch of the coronary sinus vein. Now, his pilot study shows that although there's no difference in the quality of life for 2 versus 1 LV lead, there is evidence of a better gain in ejection fraction, and also there is a further reduction of left ventricular end systolic volume by use of the 2 LV leads. Although there is a trend but insignificant reduction of the quality of life score. So that means a better quality of life score. However, we also have actually seen that the recently announced multi-center studies during the Heart Rhythm Society meeting, by comparing 1 and 2 LV leads, do not actually which did not find major difference in the outcome measures. We suspect that might be related to some selection bias in these studies, because it has been suggested that those patients who might benefit from 2 LV lead implantation might have already received the therapy, and therefore these patients were actually not enrolled into the study. And also there might be other issues in relation to the implantation of multiple LV lead. For example, there might be a higher percentage of technical failure, which is about 15% in the pilot study. And also, there has been some recent suggestions of using a so-called quadrupolar left ventricular lead, which has 4 poles and gives 2 levels of left ventricular stimulation. However, we know that a quadrupolar lead is not equivalent to LV lead, because the electrical stimulation is further apart by using 2 LV lead at different regions of the left ventricular wall. And also there might be an issue of faster battery drain by using 2 LV leads. Now what about the narrow KRS? Now, is it suitable for CRT patients nowadays for the use in those narrow KRS patients with mechanical dyssynchrony? Well, based on the published ECHO CRT study, which has been announced during the European Society of Cardiology meeting, we know that this might not be a very viable option. Now, the ECHO CRT study is a multi-center study that compares the use of ICD versus CRT-D in patients who got an impaired ejection fraction of less than 35%, and also a relatively normal KRS duration of less than 130 milliseconds. And majority of these patients will have some level of dyssynchrony, which is usually judged by the use of the radial strain, and a small number may be based on the use of the so-called MO echocardiography, and also a small number on tissue Doppler. Now, to cut the long story short, this trial actually found that there's no evidence of a significant improvement of all-cause mortality or heart failure by comparing CRT and the control arm, which is ICD therapy. Furthermore, in fact, in subgroup analysis, in fact, there is a trend of a higher all-cause mortality by implanting CRT in these patients. Therefore, it has been suggested that for those patients with a normal KRS duration, these patients should not be candidates for CRT, irrespective of their level of mechanical dyssynchrony. Now, what about those patients who got a mildly reduced EF between 35 to 50% with a Y complex and LBBB? We have some pilot study to suggest that this patient received the CRT therapy in the Y KRS setting will have improvement of ejection fraction and reverse remodeling of the heart. However, we know that furthermore, we also have our in-house data to support the notion that, in fact, patients with mildly reduced EF between 35 to 50% will also have high level of mechanical dyssynchrony, which is very similar to those quantiles of lower ejection fraction heart failure patients. On the other hand, there has been some technical hurdles of conducting clinical studies. So here is the MADE-HCA trial, which was sponsored by Boston Scientific. It is an Asian-based multi-center study using LV pacing for heart failure patients with a ejection fraction between 35 to 50%. and with a YQRS of more than 150 milliseconds. Although this is an ideal setting, however, the study was terminated prematurely due to difficulties in case enrollment. And in our center, we actually have screened about 67 patients, but then we actually could not identify any suitable heart failure patients for the study. So it illustrates the difficulties in finding out this subset of heart failure patients. Another study which is still under planning is a Miracle Mid-EF study, which is sponsored by Medtronic. Again, it is Asian multi-center study using biventricular pacing for borderline EF and also a YQRS. However, I understand up till now this study is on hold, probably because of number of practical and economical consideration. Now, what about studies that support the use of CRT in the pacing population? Now, we know that in pacing population, there might be different scenarios, including those patients who need a pacemaker also have impaired ejection fraction. So let's discuss this group of patients first. I think the most enlightening trial was the Block HF study that actually tried to examine and compare biventricular pacing versus right ventricular apical pacing in patients with AV block. So they are heart block patients who are pacing dependent and also with a reduced EF less than 50%. So this study is a one-to-one randomization. Now, take note that these patients will receive either CRT pacemaker or CRT defibrillator, and for those receive CRT-D, as expected, they have a much lower ejection fraction of 33%, while those patients receive CRT-P will have a ejection fraction of 43%, so which is higher and usually not that indicated for ICD therapy. Now, the study, however, shows that the primary endpoints, which is a combined mortality, heart failure events, and also the improved prevention of left ventricular remodeling, which is measured by the left ventricular end systolic index. You can find that in here, the biventricular pacing arm is superior to the RV apical pacing arm with a relative reduction of combined endpoint of 26%. And this is consistently true for CRT pacemaker or the use of CRT-D. And this is another primary endpoint of mortality or heart failure events, including emergency room care and hospitalization. Again, there is 27% reduction of the primary endpoint, which is highly significant. Therefore, nowadays, in fact, the guideline actually advocate the use of CRT in patients who are pacemaker dependent with a impaired ejection fraction, because once you implant a patient with a CRT, with a pacemaker device, without CRT, you will induce left bundle branch block and therefore worsening myocardial function. Therefore, prophylactic CRT is actually recommended in that situation. Now, what about those patients who are pacing indicated but with a normal ejection fraction? Is there any role of prophylactic pacing by using biventricular pacing system instead of using RV pacing? Now, that actually is answered by a number of studies. First of all, based on pathophysiologic mechanisms, we know that if we implant patients with a conventional RV pacing, it will induce left bundle branch block. Therefore, it will cause electromechanical dyssynchrony, and as a result of that, it will cause in the reduction of mechanical efficiency, virus shifting of the pressure volume loop. There will be adverse remodeling and also adverse hypertrophy of the heart. Over time, there will be issues related to impaired myocardial perfusion due to dyssynchrony and also activation of neurohormones, including renin-angiotensin system and also sympathetic nervous system. And also there will be negative feedback due to increase in the wall stress. So it will set up a vicious cycle. So here is an example of a large cohort of pacing population that we perform an acute study of pacing on and off, and we make use of 3D echo to try to map out the level of dyssynchrony. This is an example of a patient during pacing on. There is a much higher level of dyssynchrony, and you can see the regional color coding showing some early and some late delay region of contraction. Now, when we assess this cohort of 93 patients, we find that during acute pacing on versus off period, there will be high level of dyssynchrony, there will be lower ejection fraction, and also there is some acute enlargement of the left ventricular end systolic volume. So there is definitely some acute hemodynamic effect. Now, what about for long-term therapy? Is there any role of prevention? So that is actually the question being asked in the PACE study. That is the Pacing to Avoid Cardiac Enlargement study that our group published on a multi-center scale a few years ago. Now, this study actually compared 177 patients who are randomized either into a RV apical pacing or biventricular pacing. Now, this patient got a very narrow KRS, which is 107 milliseconds, very well balanced, and the ejection fraction is very normal, about 61 to 62%. Now, we make use of the 3D echo as a primary endpoint for assessing left ventricular end systolic volume as well as ejection fraction, because we know that 3D echo is very accurate, and also it will increase statistical power and reduce sample size. Now, at 1 year, we actually observed that those patients received biventricular pacing will have a 7% reduction of ejection fraction, which is actually prevented by the use of biventricular pacing. And here, it shows that there is evidence of adverse remodeling with increment or increase in the left ventricular end systolic volume by about 8.1 cc in the RV apical pacing group, and that was actually prevented by the use of biventricular pacing. So this has been announced during the AHA at the late beginning clinical trials, and subsequent to that, we actually had 2 subsequent hotline in the clinical trial update session presented in ESC in 2012 and this year. So basically, we present the 2-year finding and also the long-term follow-up of about 4.8 years. You can see that, in fact, there is a gradual reduction of left ventricular ejection fraction to 9% and also 10.7% at long-term follow-up. Now, this again has been prevented by the use of biventricular pacemaker. And very similarly, there is a progressive enlargement of the left ventricle with increase in the left ventricular end systolic volume. So at 1 year, there is a relative 27% increase, at 2 year 38%, and at 3 year 50% increase in the end systolic volume in the RV apical pacing group. And again, that has been prophylactically avoided if biventricular pacing is being used. Now, we also find evidence of a higher heart failure, greater heart failure hospitalization events in the use of the RV apical pacing, which is almost 24%, when compared with only 14.6% in the biventricular pacing arm. So this is an example of a patient who received BIV pacing at baseline, 1 year, 2 year, and long-term follow-up. You can see that his ejection fraction remained the same, about 60+%, and also there's no change in the LV and systolic volume. Now, here is another patient who actually received RV apical pacing. You can find over these 5 years, the EF progressively reduced from 70%, 45, and then eventually 40.9%. So this patient eventually actually switched back into biventricular pacing mode from the RV apical pacing. And also the LV and systolic volume gradually increased from 13 milliliter to 44 milliliter. So there is clear evidence of adverse remodeling over time. Now, when we look into the mechanistic assessment of why patients may have adverse remodeling, we actually observe that the most single important parameter that predict the development of remodeling is actually dyssynchrony. We actually observe that those patients in the RV pacing group will have a higher level of dyssynchrony, which is well above 33 milliseconds as a mean, while those patients received biventricular pacing will remain in a low level of dyssynchrony as shown in here. This year in the ESC, it also has announced on the BIOPACE study, which is actually a study that randomized 1,800 patients with a mean EF of 55.4% with heart block, either receiving RV apical pacing or BIV pacing. However, this study actually, although it over long term shows some diversion of the curves, however, it actually did not show any statistical significance, and with the p-value of only was 0.08 for the mortality and heart failure hospitalization. Now, we also perform further mechanistic assessment irrespective of pacing mode. So we put all the data together and try to look into the reasons that may govern the adverse remodeling of the heart. And interestingly, in fact, the single most important factor that will determine those patients who will develop adverse remodeling is that if these patients undergoing therapy will have a high level of dyssynchrony, they will have a reduction of ejection fraction. And however, those patients without this pacing-induced dyssynchrony, irrespective of pacing mode, they will remain in a rather preserved EF. And it's also true that those patients who develop dyssynchrony will have more adverse remodeling over time when compared with those patients without dyssynchrony. This is another study from the European colleagues that technically corroborate our study, who actually find that those patients who develop dyssynchrony over 3 years, they will actually have a lower ejection fraction and also bigger left ventricular size over time. Now, right now we are conducting the ENHANCE study, which is a randomized, multi-center controlled trials in Hong Kong, India, China, and Italy. Now, the study actually includes patients with advanced AV block with a EF of more than 50%. Now, the way the treatment protocol is different. For this patient, they will randomize into either BIV pacing or RV apical pacing. And in the biventricular pacing group, if they have acute dyssynchrony before discharge, then they will actually switch to the use of biventricular pacing mode. If not, then they will remain in the RV pacing mode for the follow-up period. And therefore, we will see whether this patient who got acute dyssynchrony will be translated, will be benefited by the use of biventricular pacing. So that is a rationale, and the study is still ongoing, and about half of the patients have been enrolled so far. Therefore, we believe that in the treatment of heart block, if we use RV-based apical pacing, we will cause RV adverse remodeling and heart failure, whereas this patient, if we use BIV pacing, we will render them into more stable clinical course, and the patient will be having a more preventive role of developing heart failure. Now, in the next 5 minutes or so, I will also give you an idea of another new therapy, which is called cardiac contractility modulation, or CCM. So this is a new therapy that actually implants two electrodes at the septum, one at higher septum and one at lower septum of the through the right ventricular approach, and also the atrial lead will be implanted to synchronize the heart. So we start the program as early as 2005 as a first implant in Asia, and we also make use of hemodynamic monitoring during implantation in this patient. Now, this is a new therapy. It's an electrical therapy for heart failure. However, the concept is that this is not a pacemaker and it's not a defibrillator. It is a therapy that will deliver a large amplitude of electrical current during the late systolic and the refractory period of the heart. Therefore, it is envisaged to enhance the intrinsic contractility of the left ventricle rather than induce another additional pacing. It is intriguing device because it's actually a very smart design that once the device is implanted, you can see the coil over the surface, which will allow the use of external programmer to recharge the device. Therefore, it is a chargeable device, and the patient needs to be charged every week by about 1 to 1.5 hours. Therefore, it is a relatively easy program device. So here is an example of an implantation where the two electrodes are placed at the at the superior and inferior border of the interventricular septum on the LAO view, which is seen very clearly, and also you can see the right atrial lead, and also a velar catheter will be implanted during acute implantation for hemodynamic assessment. Now, based on the fixed HF5 study, the primary efficacy endpoint, which is a very tricky and tedious endpoint of an aerobic threshold, was actually not reached. There is actually no significant difference between the CCM treatment and the control arm. However, the VO2 max is actually significantly improved in the CCM group, but actually deteriorate in the control arm, therefore leading to a significant difference. There is also a significantly higher degree of improvement of the quality of life of these patients receiving CCM when compared with the control. And also there is a greater improvement of the heart failure functional class in the CCM patients when compared with the controls. This is an example of a patient. You can compare the baseline and also the CCM after 3 months. You can clearly see that the septal and the free wall, the lateral wall contractility is much better when compared with the baseline. And also the same patient on the short SS view, you can see that the circumferential contraction is much better than the baseline of the same patient. We also perform a study to assess the degree of reverse remodeling and improvement of myocardial function. Over 3 months, there is at least 5% improvement of EF, and also there is about 10% reverse remodeling by the reduction of left ventricular and systolic volume based on the use of real-time 3D echo assessment. This is an example of a patient who got a large area of hypo to akinetic left ventricle, and you can see that the contractility is actually enhanced after therapy, and the EF increased from 33 to 39% with reduction of LV volume. Now, what about meta-analysis? Here is the meta-analysis of 3 clinical trials that is isolated from 155 records and also 3 studies from 8 references performed in our center. So this is all-cause mortality, again consistent with previous observation. There was no mortality benefit. There is a borderline, but but it's actually a sizable reduction of heart failure hospitalization for about 36%. Although it was actually borderline in significance, but I think the improvement of heart failure events really deserve more attention for this therapy. Now, there's also a trend of reduction in the quality of life for this patient receiving the therapy. This is an example of one of my patients. Now, this patient was actually having a class 4 heart failure who are inotrope dependent almost every week, being treated in the hospital. So this patient was implanted initially with a CRT device. And then this patient, after CRT, he was deemed to be a non-responder because the EF remained low. You can see that his EF is in the order of 20%, and he remained in heart failure every week. So I actually implant him with a CCM device, which is shown on the right side. So these two are actually the CCM lead together with this atrial sensing lead. So that is a CCM device. After a couple months, his ejection fraction improved to 25%. Initially, this patient had a lot of PVCs, and actually that disappeared, and he does not need any inotrope treatment anymore, and actually he is back to class 2 to 3. So it's actually very good from class 4 to class 3. However, this patient developed atrial fibrillation. That is the enemy of CCM, because once patient develop AF, it fails to sense and synchronize, therefore the CCM will stop to function. Now this patient very quickly developed left ventricular enlargement and back into class 3 to class 4 heart failure again. So we gave him AF ablation by use of pulmonary vein isolation. Unfortunately, this patient quickly went into AF again, so it seems to be not very effective. However, after a few weeks, the patient actually developed an episode of VT. Therefore, the CRT device eventually started to its best function, so it gives a shock. After the shock, it actually ensured not only sinus rhythm, but also there's no more AF recurrence. So we believe that the pulmonary vein isolation is actually doing its own job. Now, once the patient go back to sinus rhythm, patient get out from heart failure, then the patient start to have reverse remodeling, and he is actually doing quite well in the last 5 years, and now actually back to mainly to class 1, and I never admit him into heart failure in the last 3 years anymore. So here is the indicator, you know, for the CRT device with the ICD lead and also the LV lead. So I think this is a very traditional saying from Huangdi, which is a very wise person or a doctor back to more than 3,000 years ago. So what he says is that superior doctor will prevent the disease. Mediocre doctors will treat the disease before evident, while inferior doctors will treat the full-blown disease. So I think we really have to move forward and try to prevent the disease instead of rendering patients develop full-blown heart failure who will need desperate device therapy. So I think with that, I will stop and I will thank you very much for your attention.
Thank you, CMU, for such a comprehensive overview of device-based therapy. Before we finish for the day, we may have time for a quick couple of questions. Do we have some? Have a microphone, please.
Yes.
Very much enjoyed your talk. I have one comment and one sort of a query that I'd like to clarify. As far as bradycardia pacing, BIOPACE or RV pacing, I think I can tell from our own, I mean, in India, the large experience of a lot of patients going for pacemaker, single chamber, dual chamber.
Yes.
You see, there are very few patients. People have been on pacemaker for maybe 2 decades plus. So there are few patients who do go into LBBB dysfunction. And I think no doubt that if we have some kind of a criteria identification, I think maybe worthwhile to recommend those kind of patients BIOPACE pacing. But otherwise, giving everybody a BIOPACE pacing with a fear that he may go into that, because even if your ejection fraction falls from 60 to 50%, how much clinically is going to affect the patient? Question is the cost is also involved. We have multiple leads, the question of infection, and then because these are, I mean, things we can't, do happen. So I think that is one that if we have some kind of a way of identifying. Otherwise, a patient maybe sort of have some goes into LBBB dysfunction, probably you can upgrade it. But everybody going on, I think the cost is going to be a major issue, particularly in country like ours. One, I'd like to just have a sort of clarification from you that when we talk of wide cure as non-LBB for pacemaker indication, do we include right bundle branching into that, or no, they are not included?
So, you know, to get a short answer to your questions, I think the first issue is well addressed. Not every patient receive a RV-based pacing will develop a problem of heart failure. Now, actually, we have another study that I didn't mention, but I think we have looked into the pacing population who induced with LBBB. We actually found that there's about half of the patient with pacing-induced LBBB will develop dyssynchrony, while the other half will not. So, but we really don't know what are the factors that will actually predict those who will develop dyssynchrony. So it's very difficult based on the clinical or whatever available parameters to find this out. Over long-term follow-up, this patient might eventually develop heart failure. You're absolutely right that there's only a small number of patients who will actually develop a rapid course of decompensation after pacing, leading to heart failure who will need an upgrade. So there's no doubt that this patient will need an upgrade. So I think the message, of course, is that we are not trying to advocate the use of BIOPACE pacing for every patient because of the cost. I think there's a learning curve in implantation. There might be a slightly high risk of implantation, etc. But rather, we should actually find the best way to maintain the balance and also to try to identify the high-risk group of patients. If we can find them out, give them a BIOPACE pacing device, I think that in the long term will be helpful. Now, come back to the non-LBBB population. Now, as you know, based on the current guideline, it's because the first guideline that developed in 2003 suggests to implant everybody with a KRS of 120 or 130 milliseconds. Therefore, I find from the electrophysiologist's point of view, it's very hard for them to convince not implanting CRT devices, and therefore I think there is also under certain pressure as driven by the device company as well. Therefore, in the newest guideline, they only say that if you have a non-LBBB patient, you need to have a KRS of more than 150 milliseconds. So that means they have cut down a small number of non-LBBB with a KRS between 120 to 150. Okay, but in my opinion, it's quite likely that these patients with a non-LBBB pattern, they are actually not responding to CRT at all, or only a very small number. But I think the challenge is it's very hard to, based on the ECG, to actually dissect out what are the small number of patients who may remain benefit. And that's the reason why the guideline keep this group of patients. Now, if you ask me whether there's any method or not, I would say yes. You know, if you can able to master a good technique of tissue Doppler or other Dyssynchrony assessment, it's definitely predictive of the response. Therefore, you can even narrow down the implantation only in the right KRS with Dyssynchrony. But then this is very difficult to advocate in the general or broad population in the pacing circle because of the challenging or difficulty in the teaching and the publication of the skill. That's why they still include a right KRS complex as such.
Okay, remind me never to ask for a short question or a short answer again. On that note, I'm sure everyone, thank you to say Sim Yu again for a comprehensive talk. Thank you, Sim.